guest speaker today is Dr. Jessie Berry, who is fantastic and so fun to listen to. She hails from California, and we're so grateful to have you here, Dr. Berry. Just a special thank you as we get started to our sponsor for the webinar series, Castle Biosciences, who has helped to make this possible. So with that, I'm going to go ahead and turn the time over to Dr. Jessie Berry.
Thank you so much. It's such an honor to be here. And to those who are joining in or watching later, unfortunately, I'm the tiniest bit sick. So if I cough or need to stop to take a quick break for my throat, please stick with me. So I'm going to do the first part of this exciting webinar today, talking about the navigating a uveal melanoma diagnosis and a little bit about the roadmap from the eye cancer, the ocular oncologist side. I do have some research funding, and I am going to talk today about some trials as well as some companies that are in the ocular oncology space. I actually don't have relationships with any of them. I'm just sharing information. So if you're here, you likely already know this, but uveal melanoma has a whole spectrum of disease. And so you hear a lot of terms thrown around with it, including even ocular melanoma, which really includes melanoma all throughout the eye or ocular space. But when we talk about uveal melanoma, we're really talking about melanoma that's involving the iris, the ciliary body, which is the structure that produces fluid for the eye, that hides behind the iris. And then the pigmented layer under the retina is called the choroid. And we see a lot of tumors forming there as well. So these are the structures that we're talking about when we talk about a diagnosis of uveal melanoma. And uveal melanoma actually is a minimal contributor to the total amount of melanoma that we see. Most, of course, are cutaneous or on the skin, but it does account for about 5% of melanomas in the United States. It is the most common primary intraocular tumor in adults, and primary means it started in the eye. It didn't come from other parts of the body. There are about 6 cases per million, which is about 2,000 in the US. And so that means that this is a rare disease. And so anything that is rare means that there are fewer specialists that treat this disease. I love seeing a cure in sight, and other groups come together to provide support for patients and resources, and for all of you showing up and spreading the word, because again, this is a less common diagnosis and disease. And so when we think about people who are at risk for melanoma, we often have this very stereotypical picture in our head of somebody who's maybe older than 50 years. Men and women are equally affected, but we think about people who have light hair, light eyes, and oftentimes we think about sun exposure, although that's actually very argued. But these are the risk factors we think about when we're talking about melanomas in general. By the way, sun is not argued for skin. But who's really at risk for melanoma? Well, everyone. So in my practice in Los Angeles, I have seen people under the age of 18, so children diagnosed with melanoma, although that's exceedingly rare, very old people, every age in between. If you are an adult in your 20s, it does not mean that you cannot get melanoma. Unfortunately, I've treated many of them. And if you are not light hair, light eyes, it does also not mean that you cannot get melanoma. Unfortunately, while the risk may be different, the risk still exists for all people. And so because of that, you see a lot of episodes through this podcast, but we do recommend a dilated yearly eye exam to check for these things. And the reason we recommend a dilated yearly exam is that melanoma is really a clinical diagnosis. So what does that mean? Doctors understand what that means, but what does that mean for a patient? Well, for a patient, it means that you need a doctor to look in the eye and do some imaging in the eye for us to be able to diagnose melanoma. And by and large, we are about 99% accurate in diagnosing melanoma based on these features when we decide that something has progressed to melanoma. And I'll talk about that as well. So this clinical diagnosis for ocular melanoma being so high is in comparison to cutaneous melanoma, where the biopsy positive rate for something that's possible melanoma is only 10%. But that doesn't mean that ophthalmologists are better clinicians than dermatologists. I wouldn't say such a thing, but rather that the threshold to biopsy a skin lesion is very low. You can take the whole thing off. And get a diagnosis that way. Now, there are several predisposing conditions for melanoma. There are some predisposing conditions that can lead to melanoma, and this includes nevi, and I'm going to talk about that a little bit later, melanocytomas, which are sort of an aggressive looking nevus or mole in the eye, but actually have a lower risk overall of malignant transformation. And then something called ocular melanocytosis, which you can see down here. This is also called nevus evoda. Patients who have this actually have a very high risk of development of melanoma, and we recommend that they are screened very frequently. Now, you might be referred to somebody for melanoma and not actually have melanoma. That also happens a lot. And so there are various lesions, spots or dots in the eye that are not actually melanoma. These can include choroidal hemangioma, chirpies, choroidal hemorrhages, metastatic disease. As you can see here, this is from lung, or even osteoma. This is a bony tumor that can form in the eye. And so let's jump in a little bit to the path to diagnosis. So often what happens in my practice is someone is told that there's a spot in the eye and they're going to be referred to the specialist. And then they find out that the specialist is an ocular oncologist. They hear the word oncology and start to have a freak out, although I see all different kinds of spots, including on the left here, which is a melanoma, and on the right is a nevus. So just because you have a spot and just because you're referred to an ocular oncologist does not already mean that you have a melanoma. What is an ocular oncologist? Well, an ocular oncologist is an ophthalmologist, which is an eye surgeon who has specific training in the management of benign and malignant tumors. Sometimes these people may also be retina trained or specifically ocular oncology trained. And so this is from a Google search that I did this morning of me to find my profile, but Google can sometimes be a great way to find someone. But you'll see if you look at people's profile, usually what you would see is somebody who says, like here, subspecialty training in ocular oncology. Finding an ocular oncologist sometimes is the first part of the journey to a diagnosis. Now, if you're in LA or in the California area, there's several of us in the state, but there are states where there are no ocular oncologists in the whole state. And so it's important to know that there are various means or mechanisms to identify a physician who has the skill set to treat somebody with a melanoma. And so this is from imelanoma.org, but it talks about all of these different areas where you can find an ocular oncologist, including from a Kieran site, the American Academy of Ophthalmology. There's some European sites, and then also the Eye Cancer Foundation. And dare I say it, in this day and age, you can also go to Facebook or Instagram. This again is from this morning. If you do hashtag ocular oncologist this morning, this is what comes up. And actually, you would see me in two of these. You would direct to my profile as well as to some of my colleagues. So once you get to your appointment, what should you expect? Well, ocular oncologists love imaging. And so you should expect that you will spend a significant amount of time with your eye being imaged. And that's usually not done by the ocular oncologists themselves, but rather by a team of dedicated ophthalmic imagers. They will take photos of the eye so that we can identify the tumor and the margins of the tumor. You may have something called fluorescein angiography or a dye test where they inject dye into the arm, or sometimes have you drink it orally so that we can see the vasculature in the tumor. And then sometimes you may also have something called optical coherence tomography or OCT. This is really done for us to understand the status of the retina, which is the structure overlying the tumor, as well as the extent of fluid, which you see is dark black here. And that can be very helpful, particularly in small tumors. You'll also have an ultrasound. One of the main questions my patients say to me is, Dr. Berry, why did they do the ultrasound on my eye? The referring doctor did it over my eyelid, and that varies a little bit center to center. But to get really good images, often you'll have a numbing drop placed on the eye, and the ultrasound will be done on the eye itself. Screening ultrasounds that are not quite so dedicated might be done over the eyelid, and we do the same thing. The ultrasound is a very sensitive modality for us to not only identify the location of the tumor, but to measure it and to understand which structures are impacted by its growth. Well, this talk is not at all about choroidal nevi. I felt like I should at least spend a minute on it because so much of the very initial referral might be regarding, is this a nevus? Is this a melanoma? And I think there's a lot of anxiety and misunderstanding as it relates to this for patients. So choroidal nevi, by definition, just like moles or freckles on the body, so nevus is a medical term for mole or freckle, are benign, meaning they are not malignant. And often the good nevi that we see in the eye might be dark brown or gray, they're flat, and they have no high-risk features. However, if they do have certain features, which we'll discuss, they really need to be monitored because all of these lesions could change at some point into a melanoma. And so choroidal nevi are actually relatively common. This is from a prevalence study looking across multiple publications and found that about 5% of an older Caucasian population will have choroidal nevi. And most of these tumors, so when nevus is still a tumor, it's just not a cancer, are asymptomatic. Again, this is another reason why you need to have that dilated yearly exam, because you might have a nevus and not know. But growth or change of this nevus might cause different changes that we see in the eye, which include drusen, changes in pigmentation, the presence of fluid, or the presence of something called lipofuscin or orange pigment is how we often describe it to our patients. And size also matters, but is not the definitive defining feature. So if you look in textbooks, most textbooks will say that a lesion around 5 by 1 millimeters is by definition of a choroidal nevus, although all of us who've treated melanoma have seen very small tumors in that range as well that are worrisome. And you can also have giant choroidal nevi, as you see here, that have been followed and are stable in the eye for years and years and years. However, they're quite large. So size alone does not diagnose someone as having a nevus or a melanoma by any means. But these nevi need to be monitored. And this is from a study by the Shields, who are ocular oncologists in Philadelphia. And there are some factors that tell us that there's an increased risk of a nevus turning into a melanoma. And that includes thickness greater than 2 millimeters, the presence of subretinal fluid, the patient noticing symptoms. Symptoms are usually a sign that something is growing or changing, the presence of orange pigment, and whether the tumor is close to the disc or on ultrasound looks hollow. So some of these features, people who are listening, patients listening to this podcast might know because they're being followed for a nevus. And that includes the idea that it could be thick, especially thicker than 2 millimeters, whether it has fluid or orange pigmentation. And these are factors that, to me, mean, if possible, if you're in a place where a retina specialist or an ocular oncologist with training in melanoma can monitor you, they should. And the reason they should is that these grow. And so if you have 5 risk factors, you have a 27 times the risk that this nevus will grow. Growth is not a guarantee that it's turning into a melanoma. Again, you can have these larger nevi, but growth is very concerning for metastatic change, for malignant change. And we don't want to see growth unchecked and unfettered for this metastatic risk. So a growing nevus absolutely needs to be referred. And so again, just showing how important it is for you as the patient to understand these risk factors and to interact with your doctor to make sure that you're referred appropriately if you have one or more. Many times when I get a patient referred for this nevus melanoma question, the first question they ask me is, what about a biopsy? And again, I think this comes from the fact that 95% of the melanomas that we hear and talk about are these cutaneous melanomas. And so it's very well understood by patients that if you have an atypical mole or a mole that's changing, your dermatologist will take that mole out and have it biopsied for evaluation. And that works really well for moles on the skin because while you might have a small scar, you're otherwise okay. In the eye, I hope you see my mouse moving, but in the eye, there's the optic nerve and here's the fovea. And this mole, this was actually a nevus that's been stable now for a long time, but this mole is in between the 2 most critical structures for vision in the eye. So one, I can't take that out. If I take that out, I permanently destroy vision. And frankly, to take the whole thing out, I would permanently destroy the eye itself. So I cannot remove this easily. I could do a biopsy where I take a needle and take a few cells for analysis. It's still a very small tumor in a very critical spot, and so there's risks to the patient. But even if I do a small biopsy at that moment in time, and they tell me that the nevus is a nevus and it's benign, it doesn't mean that it doesn't need to be monitored because in 2 years or 5 years or 10 years, it could still transform into a melanoma because it hasn't been removed. And so I spend a lot of time explaining this to my patients and making sure they understand this. I hope that in the future, we will actually use liquid biopsy to better follow these and to give some more definitive information to our patients. I'm not going to talk about that anymore on this podcast, but we did a podcast already on this. And so you can listen to this a little bit more if you're interested. So because we don't biopsy these currently, we monitor these closely. And why do we monitor these closely? Well, here is one of my favorite examples of this. So these are 8 patients that all have high risk nevi. So that means a nevus a choroidal tumor in the eye that shows some features that are concerning. We, even as ocular oncologists, are not sure 100%, is it a melanoma, is it not? So we watch for a short interval. And you can see here, some of these, half, will be completely stable and not change, and the others will go on to change or grow. And that change or growth tells us definitively, this is an ocular melanoma. This is a patient who needs treatment. So when to ask for a referral if you have any of those risk factors or if you have any associated systemic disorders. So now that we've discussed the early diagnosis and the nevus versus melanoma tension, let's talk about some uveal melanoma treatments. And I thought I would give just a quick overview on the treatment timeline and the history of treatment of melanoma. So prior to the 1960s, enucleation was the primary diagnosis in the US. And I like reminding people that because the 1960s weren't really that long ago, right? And so a lot has changed in this rare disease in a short period of time. And even in the 1960s, unfortunately, there was about a 20% misdiagnosis rate. It might have been other things that were growing or changing in the eye. So we've gotten better at diagnosis and better at treatment. In the 1970s, there was some thought that the enucleation itself, the manipulation of the eye, caused tumor spread. Now, that has been completely debunked. I don't want anyone to worry about that. We know that that's not true. But that led people to think, okay, is there something that we can do that is not going to cause tumor spread? Again, take home, it was not causing tumor spread, but they wanted to see if there were any other options to manipulate the eye less. And in Europe, people were doing plaque brachytherapy or various forms of radiation therapy to the eye in order to save these eyes with melanoma. So in the mid 1980s, again, not that long ago, I was alive, right? We in the United States designed the collaborative ocular melanoma studies in order to specifically evaluate whether it was safe to treat patients with this form of radiation, where you take a plaque loaded with radioactive beads in order to save the eye. And these were very well designed, long prospective studies funded by the National Eye Institute. And there are many collaborative ocular melanoma studies, but the three main ones were basically the large, the medium, and the small tumor trial. And the idea for the large tumor trial was, does a patient after they have eye removal need radiation? Because a lot of radiation was being done at that time. And we found that there was no added benefit to radiation. So this is why we do studies, right? To really understand, is something helping a patient? Is it hurting a patient? Is it not doing anything? What should we do as a group? And so the large study helped us move away from radiation after the eye was removed. The medium study ushered in a whole new era of saving these eyes. Again, prior to this, the treatment was to remove the eye. They looked head to head at eye removal versus brachytherapy and found that the outcomes overall, in terms of the patient surviving, not the eye, but the patient surviving, were equivalent, and that it was safe to offer eye salvage therapy for patients with medium-sized tumor. And then for the small tumors, again, specifically because of this tension in some of the small tumor studies, the idea was, can you safely watch and monitor these? And the answer was yes. The risk at 5 years in terms of overall patient survival is low. We know we can monitor them to make very sure that we're dealing with a melanoma before treatment. Around that same time in the 70s to 80s, proton beam, which is another form of radiation that is external, it's charged particle radiation, and a beam of that is literally placed into the eye to target the tumor, was also gaining popularity. And the first was the Harvard cyclotron. And by the mid 2000s and now even past, there's 20 or more centers that do this type of radiation therapy for ocular tumors. So the charged particle irradiation has some advantages to brachytherapy in that you don't have to have two surgeries, and the surgery that you do have is somewhat smaller to place clips in the eye. It gives a very uniform dose of radiation, but it also radiates all structures from the front to the back of the eye, where the brachytherapy radiates the structures local to the tumor and not so much to the front of the eye, unless your tumor is in the front of the eye. In the late 80s to current, people, including USC, where I have my ocular melanoma practice, started to look at various forms of plaque brachytherapy to make the treatment of brachytherapy even better and even more localized. And they designed the USC iPhysics plaques, which are frankly one of the most common plaques now done throughout the US and the world. And again, I played no part of that, but I get to benefit from using them. We call these personalized eye plaques. So you talk about personalized medicine. It means you take information about the patient, you design your treatment to that. These personalized plaques are similar. So we take imaging from the patient, make a 3D model, and design the plaque around the patient. So it is not a one-size-fits-all plaque. You are not getting the same plaque as the person who was treated several weeks before. The size, shape, and dosage is really for the patient and for the patient's tumor. And that's done to limit radiation toxicity to other structures in the eye. And so there's a 3D modeling process that's used for this to overlay the plaque onto the tumor in the eye using both the ultrasound and either a CT scan or an MRI of the area called the orbits, which is the area around the eye, again, to make sure that that plaque is fitting within the patient's ocular space to best treat their tumor. And then we use very specific markers to make sure that during the surgery, we know exactly where to put the plaque in the eye. So I'm going to share, I think I have time. Yep, I still have time despite a little cough. I'm sorry again about that, but I'm going to share a 2-minute surgical video of placing a plaque. So if you are sensitive, you don't want to see an eye surgery, please close your eyes or turn away. Once it's done, I'll let you know. And it moves fast. This is 4 times speed. I don't actually operate this fast. So this is showing the 3D process of taking the images from the CT or MRI and the ultrasound to perfectly design a plaque for that patient's eye and that patient's tumor to give the highest dose of radiation to kill the melanoma without as much radiation to other ocular structures. It's not zero, but we try to limit. People ask, how do you get into the eye? Well, you have a skin on the eye called the conjunctiva, and we open that up. And then very delicately, we mark the exact location. This is an ocular muscle. I don't always have to take these off, but I like to show that sometimes you do. And then you mark again using the plan. It's all planned out. You know exactly where the patient's tumor is. You mark where the plaque is going to go on the eye wall. That white part of the eye wall is called the sclera. And it's about 1 millimeter or so thick. It depends on which part of the eye you're placing those sutures. But you place that just there on the eye wall. And the first thing you do is put a dummy plaque in. So you saw that was hollow in the center. You make sure with ultrasound that that plaque is exactly where you want it to go. It's covering the tumor nicely. And that's when you put the heat on. You put the hot plaque on that has the radiation seeds. You suture or tie it down in place. You close everything up, and then the patient goes home. The timing of plaque is dependent a little bit facility to facility, but then the patient comes back and it's removed in the OR several days or a week later. And here you can see gently releasing those sutures. The plaque removal, I do my plaque removals in the OR. I think it's more comfortable for patients, but that's not done everywhere. You remove that plaque. It's again, a very quick thing. You close everything up and the patients heal up really nicely. So let's talk about some options for treatment today based on size of tumor. So for patients who have small tumors, again, brachytherapy or proton beam, we've just gone over the history of both of those and the way those two mechanisms of radiation are applied, are standard of care treatments for small, medium, and even large tumors. However, we're in an era now where we have more trials, which is really exciting. And as somebody who treats these tumors, these didn't exist, 10 or more years ago when I started my practice. And so I'm really excited about them. One such trial is the COMPASS trial. Again, I am not sponsored by Aura. I don't work for Aura. I'm just sharing information about this trial. And I actually, if one of my patients is interested in this trial, I send them out to an enrolling center. So what happens in this trial is there's an injection of a medication into the eye called Belsar. It's a novel therapeutic that sort of has a virus component to it that allows an affinity for these tumors. And then there's a laser, and the laser actually activates the drug right in the tumor. As ophthalmologists, we're all very good at aiming laser beams into the eye. We do this for lots of indications. And so we can then very specifically activate the drug over the tumor. However, for you to be eligible for a trial like this, you need to have a small tumor. The tumor thickness needs to be less than 2.5 but also more than 0. We want to make sure that we're actually treating these high-risk early lesions and small melanomas. And you also need to have some documented tumor growth, again, for that same reason. So you can follow the QR code to find out more about that trial here. In general, for the medium tumor trials, again, brachytherapy and proton beam are standard of care, although this is changing a little bit as well with some early news from some of our large tumors. And this includes a trial from IDEA Biosciences. And so in this trial, they're using Daro, which is an oral medication. It's a small molecule inhibitor of protein kinase C, which is something that we know to be activated in these melanoma cells. And so you can turn it off. This is also actively enrolling for patients who have tumors that are planned for enucleation or brachytherapy. And hot off the press, as of June 3rd, the company released some early results from their initial trial. And what they found is that from 12 patients who were planned for enucleation or eye removal, 9 of them were able to preserve their eye by taking Daro for 6 months beforehand. And so their take home was that this is not taking the melanoma away, but it's providing meaningful shrinkage of the tumor to either avoid enucleation or provide a smaller dose for brachytherapy. And so this is evolving. Lots of more information will be released, I'm sure, in the future. At the time of whichever treatment you choose, most physicians will talk to you about a biopsy. Now, it is my practice to offer a patient a biopsy, but let them choose whether or not they want it. Most of my patients, but not all of them, do. And for very, very small tumors, like less than 2 millimeters that are right next to the fovea, I might not want to biopsy those patients because I think the risk may be greater than the benefit. The likelihood of them having a high-risk tumor profile is low, but this is all something that you need to understand and to talk to your doctor about because there are options here. And as the patient, you should be empowered to activate those options and make a choice that's right for you. So the biopsy that's done is usually an FNAB. That means fine needle aspiration biopsy. So again, doesn't mean we cut the whole tumor out, but instead it means we take a small needle about the size of, 10 or more human hairs put together, place it in the tumor just to take some cells out. It is in general, again, not done for diagnosis. We already talked about that as it relates to the nevus versus melanoma question, but rather it's done for prognosis. And the prognosis that we're looking at right now is the prognosis that this tumor will show up in the body in the future. So prognosis for metastatic disease. In my practice, the biopsy mechanism that I choose to identify prognosis is use of Castle Biosciences. Again, I don't work for Castle Biosciences, but Castle Biosciences uses a gene expression profiling assay, which basically means it tells us which genes are turned on and which genes are turned off in the tumor. And we know from very good studies that this helps us prognosticate how likely it is that the tumor might show up in the body. There are also, aside from class 1 and class 2, there's also BAP1, monosomy 3, and PRAME. This is other information that you may get. Some of this comes from Castle. Some of this comes from other types of biopsy, like cytogenetics, that may be offered to you at your center. So just understand if a biopsy is offered to you. If it's not, you should consider asking for a biopsy and understand what kind of biopsy it is and what are the biomarkers that you are going to get. From Castle, this is the kind of results that are given to the patient. Patients with class 2, of course, have higher risk of developing metastatic disease. And then you're in a good position to really understand what sort of surveillance you need as a patient. And so other factors that are clinical also impact your risk of metastatic disease as a patient. And that includes age, involvement of the ciliary body, the size of the tumor, both the thickness and the diameter of the tumor, and again, that chromosome 3 status. Chromosome 3 is higher risk. But what has shown in several studies to be the most predictive is, in fact, this gene expression profiling class. And so that is why in my hands, this is the test that I use. I also, at diagnosis, stage my patients. So I cannot tell you how often I'm asked, well, Dr. Berry, I already have an ocular oncologist. Why do I need another oncologist? Well, cancer in the eye, I believe, should be staged in the same way that cancer anywhere else in the body is staged. And so the American Joint Committee on Cancer is the group of researchers and physicians that come together to provide staging guidelines for patients with cancer. And those guidelines are specific to each type of cancer. And so for melanoma, the staging is based on the size and extent of the primary tumor, but also whether or not there's any sort of metastatic disease found in the body at that time. To determine that, you need to have baseline staging scans. In my hands, I generally do a CT of the chest, abdomen, and pelvis. Other places might do something different, but that's my preference. And then again, particularly if I'm planning brachytherapy, I will get that imaging around the orbits. Now, I have heard via some patients who come to me or at academic meetings, people will say, we don't need to stage these patients with melanoma because the risk of them having metastatic disease at diagnosis is very low. And that's true. Thankfully, the vast majority of our patients do not have any metastatic disease at diagnosis. However, we do know that with this cancer, many patients, unfortunately, will go on to develop metastatic disease. So I believe that it is important to have that baseline staging and to partner with a medical oncologist and have the patient followed with a medical oncologist. I don't want to get a 5 p.m. Friday call, Dr. Berry, the ultrasound showed something in my liver and I don't have someone to call to help me. I can't treat liver disease. So I feel that it's really important to have a team-based approach. And thankfully, one of my colleagues from the other side of the country will be talking to you guys about this shortly. The last thing that I'd like to talk about before we move on to some Q&A and then before I hand off to Dr. Orloff for her part of this webinar is another really common question I get from my patients. So their question is, well, what treatment, all this sounds great, Dr. Berry, but which of these treatments is going to bring my vision back to 2020? And unfortunately, the answer right now is that we do not have a treatment that is going to restore someone's vision to 2020. And in fact, unfortunately, the radiation therapy that we do is really very good, 98% or better at killing the main tumor in the eye, the melanoma that's formed in the uveal tract, and maintaining it. So that's really high success. We're really good at that. But the dose that needs to be used to kill the tumor is a dose that can cause damage to structures in the ocular space. So as I discussed, there are many people around the country and the world that are working on different ways to maximize the dose of radiation that's needed to the tumor itself, but to decrease it to the ocular structures. And so we've done that with the USC iPhysics plaques, the IDEA trial that I discussed. So the idea there is you shrink the tumor down again to prevent enucleation, facilitate radiation, and to decrease the dose of radiation that might be needed for an eye, all with the goal of maintaining as much vision as possible. Other things like diabetes, young age, use of chemotherapy might impact vision. And there are also some ongoing trials, including some that I hope will be opening up later this year or in 2025, looking at injections or other therapy for patients. Unchecked, you can see that radiation can continue to cause damage in the eye. So again, this is why it's really important to be in a place where you can partner with your ocular oncologist, the retina specialist who's treating you to maintain the vision, and with the medical oncologist to monitor the body. So in conclusion, uveal melanoma is a rare tumor. You need a team, and you need a team with training for this rare disease, including an ocular oncologist to diagnose and manage the eye, including the treatment sequelae as it relates to vision. Thankfully, we have new trials for better treatment salvage. And I think it's really important that each patient understands the role of biopsy, whether they want a biopsy, and if a biopsy is being done, what in their case is it looking for. This is from our team and my two daughters, Daphne and Lily. It's a real honor for me to be part of the ocular oncology community. I spend my days doing melanoma in adults and then retinoblastoma in children. It's very rare to basically focus on two diseases as a physician, but I love it. Our team loves it, and we're